Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm speaking to GP Dr. Emma Watts, who's a dispensing doctor based in Surrey and the chair of the RCGP's Rural Forum, about the distinct challenges facing rural general practice. In this conversation, Emma discusses how urban-centric policies, mounting financial constraints and operational pressures are driving rural practice closures. She also highlights hidden health inequalities in rural areas such as homelessness and explains why the government's proposed framework for a neighbourhood NHS fails to consider the reality facing remote, rural and dispensing practices. And we discuss the Rural Minds project, an innovative training programme using virtual reality headsets to support mental health in UK farming communities. GP Online has joined forces with 5 essential healthcare resources to create the MIMS Healthcare Network. Since 1959, our Haymarket healthcare titles have supported primary and secondary care audience across the UK through individual publications and specialist events. We're now entering an exciting new era with the launch of MIMS Healthcare Network, linking together our 6 leading media brands to serve the entire healthcare community as one. The MIMS Healthcare Network covers GP Online, GP Business, MIMS Learning, MIMS Learning Live and MIMS Pharma. By bringing together these resources, we aim to provide a seamless experience for all healthcare professionals and the organisations that support and supply the UK health sector. The MIMS Healthcare Network, covering every aspect of primary care. For more information about our subscriptions, visit GPonline.com/subscribe. I'm really pleased to be joined on the podcast now by Dr. Emma Watts, who is a dispensing doctor based in Sheer in the Surrey Hills and the chair of the RCGP's Rural Forum. She's been working as a rural GP for the past 18 years and is passionate about providing continuity of care and addressing rural inequality. And she's here today to talk about some of the issues and challenges facing GPs and GP practices in rural areas. Thanks so much for coming on the podcast, Emma.
Thank you for inviting me.
You're the chair of the Royal College of GP's Rural Forum. Can you explain a bit about what the forum does and what your role involves?
So yes, I am the chair of the RCGP's Rural Forum. That is a special interest group within the college. I joined the Rural Forum steering group some years ago because of my concerns about rural representation within the college and maybe inadequate representation in national policy. I'm pretty passionate about it, so I became chair. I really aim to ensure that all college policy is passed through the Rural Forum to make sure it's rural-proofed. I'm really passionate about championing rural general practice needs. Rural patients have different needs requiring recognition, so current policies don't adequately address the rural perspective, and the Rural Forum does provide this valid perspective that I believe should shape all college policy.
Can you explain a bit about where you practice as a GP? Because obviously I said you're in Surrey, and when people think about rural general practice, they probably think about the wilds of Wales or northern Scotland or the very north of England. But you do work in quite a rural area, don't you? And what are some of the challenges you face working as a rural GP?
So compared to my counterparts in places like Orkney or the Highlands in Scotland, it does feel that it's a bit lame to say that I'm rural when we're in the Surrey Hills. But essentially, if you're in a rural area and it's really hard to access care because there's no bus links, there's no ability to get to your hospital or to a GP surgery, then rurality creates a problem. So I am based in the Surrey Hills in Sheer. We're a rural village setting covering 50 square miles, which is dotted with villages. I think some of the problems are obviously access. Distance to the GP surgery is significant for patients. Home visits are time consuming, but they're extremely valuable. Distance to the hospital is also considerable in terms of whether patients will actually go to A&E if they're unwell. There's a thing called distance decay, which is the concept that the further you must travel to access healthcare, the less likely you are to seek it. And that contributes to that reduced healthcare utilisation in rural populations. Obviously, I've alluded to to Orkney or the remote Highlands. They've got far higher, larger catchment areas than me. But I feel that we, as the Rural Forum, are that unique place for them to belong and have a space to talk about their individual needs regarding health provision and their difficulties providing it.
There must be benefits of obviously practicing as a rural GP. I mean, what do you enjoy about practicing in rural areas?
I grew up in a rural setting. I really believe that sort of facilitates a bit of a connection with the community. Relatively, there's a bit more population stability, and I think that allows for an enhanced sort of continuity of care. I recently performed a 6-week check on a baby whose mother I also performed a 6-week check on. Shows how old I am. But that continuity builds this immeasurable trust between a doctor and a patient. It's achievable in an urban setting, but it's less likely, I guess, due to professional migration. That continuity is an absolute jewel in the crown of the NHS, and it must be respected. Obviously, another thing is I commute through beautiful scenery, and that provides a bit of relaxation before and after intense work days. But my main benefit, I guess, is feeling part of the community. We have a really active patient participation group who understand the importance of patient involvement in shaping healthcare, particularly for marginalised groups, which I think rural are. The group is really supportive of our practice's direction of travel, which is really helpful. The smaller community recognises that risk of losing general practice, and it's more prepared to stand up for it. And so feeling valued as part of the community is the best thing to take home after a busy day.
A big challenge facing GPs in rural areas, which you've talked about, is this distance from hospital services, from specialist care, from A&E as well. How does that impact on GPs day to day? Does it mean they need to practice in a different way to GPs who are nearer specialist services?
Yes, 100%. There are a couple of frustrations, I guess, around this. We need to challenge some perceptions. There's the Westminster-centric healthcare model sort of assumes that rural areas receive diluted care, and that's not fair. It's always like you're in a field, so it's not so good where you are. Rural areas present specific and unique problems, and GPs generally across the country excel at problem solving. So rural general practice serves as this hotbed for innovation. And this environment has led to significant job satisfaction as GPs find a way to make the system work. So for example, during COVID, we were struggling with patients getting access to our dispensary to collect medication. There was social distancing, there were loads and loads of problems regarding that. And we decided that the best way forward was to put in a vending machine. We called her Brenda the vendor. She's a vending machine that dispenses prescriptions. So we could text message patients a 6-digit code, a bit like Amazon Locker. They come up to the outside, they put the code in, and their medication drops down and they can collect it. That was great from a COVID perspective for social distancing, and it's open obviously 24/7. But it's a really good example of how when you're more challenged in a rural environment, you're more ready to innovate. And I think that's really exciting. So for me, that's one of the massive positives of being rural, that it's more difficult, but it's more exciting.
I mentioned at the start that you've got a real commitment to addressing inequality. And when we talk about health inequalities, people often think about, deprived urban populations as places that experience this. But it is a real issue in rural communities as well, isn't it? Particularly when, as we've talked about equity of access to healthcare. What are some of the health inequality issues that GPs have to contend with in rural areas?
Yeah, so there are many. I suppose the best example is following the example of somebody from the homeless population. So whilst urban centres like London, for example, offer a network of support services for homeless individuals, this infrastructure is largely absent in rural areas. The lack of these services creates significant challenges for us and exacerbates those health inequalities for the homeless populations. Thinking about unrecognised deprivation, rural health inequity is often unrecognised. There is this frequent assumption of general affluence in rural areas that everyone's rich, which means that these pockets of deprivation and homelessness are completely overlooked. When I first wanted to start a homeless service, people looked at me as if to say, well, I was homeless where you are. It's complete disbelief from local providers when that issue of homelessness in the Surrey Hills was initially raised. It's so frustrating. Unlike in urban areas, there's no access to soup kitchens, clothing provisions, other support services to meet basic needs of homeless individuals. Without that support infrastructure, the responsibility to provide care falls disproportionately on local general practice, which is fine because we love it. We really care about our patients, but it just changes the whole way that general practice works in a rural area. And it kind of needs to be recognised, that sort of double inequity, that you're homeless in a rural area a long way from services, and there are homeless services in the local town, but you can't get to them.
One of the other areas that I know you've been working on is that the RCGP Rural Forum has backed a project called the Rural Minds Project, which is aiming to address mental health issues in UK farming communities. Can you explain a bit about that project and, why the RCGP decided to support it?
This one I'm super excited about. So it's a really innovative training program which involves virtual reality headsets. So it's using technology to teach people about farmers' mental health. Essentially, it's a narrative story of a farmer who is struggling financially, is worried about losing his farm, which has been inherited through generations, and he's feeling suicidal but doesn't feel able to talk to anybody about it. So you put the VR headset on, and it takes you through this journey with him. And when you put the headset on, it's incredible. I've seen loads of people put the headset on and it's like they are there. They want to hug the guy. You can see them wanting to hug him. So it takes you through his journey, and then it has these stop and think moments where there's a moment where you could intervene and you could do something. And it recognizes the potential challenges of intervening, what people might be thinking. Well, if I said this, what would happen? If I said this, what would happen? And it covers all of those aspects. So it covers things like, if he went to the GP and said that he was suicidal, would they take away his shotgun license? And if they took away his shotgun license, that would take away his ability to work and also his ability to socialize, because his main socialization activity is the shoot. So it kind of covers a lot of those barriers to accessing healthcare. So we hope that by the time that people get to the end of that module, they are much more aware around farmer mental health and would manage them a lot better if they presented. I think that the next challenge for the Rural Forum is to enable those farmers to understand that they can come to us and that we're farmer friendly, that we understand.
Is poor mental health a real issue in that farming community? I'm assuming it must be because of all the financial pressures, much like general practice. These are often small businesses under a lot of financial pressure. People often very isolated. Is that why it's such a problem?
There are multiple problems. I think there's an awful lot of familial pressure. If you've had a farm in your family for years, it's your duty to keep it and to hand it on to your next generation. You can't control the weather, and so you don't know what's coming next and what's going to happen to your crops or your cattle. There's a lot of government rules that aren't helpful to farmers. Again, it kind of comes back almost to the same that I'm complaining about with general practice, that there's this urban-centric view and people don't understand what's happening in rural areas, and they assume it's just all affluent and happy.
Often in rural areas, you have got quite small practices, and over the past couple of decades, it's become increasingly difficult for smaller practices to survive given the financial constraints. Do you see more practices closing in rural areas? And what does it mean for those villages and communities if they lose a local GP service?
Yes, rural and coastal communities are bearing a disproportionate share of that burden, as small practices are struggling to survive with the financial constraints and are closing. More than 1,400 practices have closed or merged across England since 2015. Many of these fold permanently with no replacement, which displaces over 1 million patients who then need to be absorbed by neighbouring already stretched surgeries. So in terms of that rural specifics, the rural areas face structural areas that make the surgeries uniquely vulnerable, including higher running costs, recruitment and retention difficulties of younger GPs, and an older GP workforce nearing retirement. So yes, it's a huge problem.
So is it not just about the size of the practices then? It's about all of those other things that you've just touched on that make it more difficult for practices financially as well?
100%. Yeah, it's definitely not just about size.
Yeah.
Rural practices face compounding sort of logistical, demographic, operational cost pressures that make it inherently more difficult to retain financially viable compared to their urban counterparts. I suppose an example is this: just from this Tuesday, day after the bank holiday, I compared our appointment request numbers to our nearest urban counterpart. So they had just short of 1% of their population seeking advice on that day, and we had 1.9%, so double, but within the same financial budget. It's really hard to sustain that, and it's because of the lack of wraparound services. The funding formula, the core funding, is often determined by systems like the Cahill formula. It's heavily skewed towards raw headcounts, but because rural populations are dispersed over wide areas, practices frequently have smaller patient lists, making it harder to realise economies of scale, but higher overall administrative burdens per capita. And many rural practices rely on running an in-house dispensary to subsidise their clinical costs, but maintaining compliance and managing stockholding, offering fair wages, makes it really difficult to be financially sustainable.
Yeah.
Rural areas also frequently serve older populations with higher rates of multimorbidity, and they require longer, more complex consultations, which reduces the total number of patients a GP can see in a day, which is, again, another challenge. And then if you look at staffing, rurality creates that inherent labour market challenge where, in order to retain or recruit staff, they need to be able to either live in the area, which might be more costly, or own and run a car, which again increases their costs.
Is recruitment and retention of GPs a particular challenge in rural areas? Is it harder in rural areas than other parts of the country?
Yes. Recruitment and retention of GPs and allied healthcare staff is a sort of distinct and chronic challenges in rural and remote areas. We have unique hurdles like smaller team sizes leads to more onerous rotas, professional isolation, and those geographic barriers that make it difficult to attract staff. Rural GPs and nurses often work in smaller teams or in single-handed practices, meaning there's less peer support and fewer opportunities to subspecialise. If you took a job in a rural area, you might need to relocate. And relocation decisions are heavily influenced by your partner's employment opportunities, lack of local amenities, childcare, other things that sort of often deter younger or newly qualified professionals. I guess also rural practices frequently face heavy workloads, serving older demographics with complicated health needs. And additionally, many practices are dispensing practices, which makes hiring and retaining staff with the right dispensing skills and commensurate pay extremely difficult.
Many newly qualified GPs might be a bit nervous about moving to rural areas due to that fear of clinical isolation, maybe not having a big team around them. Is there anything you think the college could do to better support and upskill younger GPs to make rural medicine an attractive career choice?
One of the ways that Royal College of GPs could make rural practice more appealing is by building strong sort of mentorship networks and linking new GPs with experienced rural doctors who can offer guidance and reassurance. And we're sort of trying to do that through the Rural Forum in terms of if anybody who's training expresses any kind of interest, we're inviting them into our steering group so we can kind of try to nurture them and connect them up. It would be really good if we could expand sort of flexible training programs that allow young GPs to experience rural practice sort of in shorter stints during their training so they get a taste of it without feeling isolated and without feeling committed. Obviously, of course, the Royal College could put in lots of CPD and regular peer support to try to encourage people in that area. We could maybe do virtual meetups. There's lots of things that could be done. But I think the core requirement is to allow training GPs to sit in rural general practice so they can see what it's like.
Yeah, that's a really good idea as well. One thing I particularly wanted to talk to you about is this whole idea of a neighbourhood NHS and how that might work in rural areas. Obviously, the government wants the NHS in England to shift to this new model where neighbourhoods cover a population of around 30,000 to 50,000, about the size of PCN. But in rural areas, as you've sort of mentioned, that's probably over quite a massive geographical area. How do you see neighbourhoods working in rural communities? Do you think it can work?
I'm hugely frustrated about the neighbourhood health framework because it fails to mention remote, rural, coastal or dispensing practices at all. They are literally not mentioned. Pharmacy is explicitly referenced as the first point of contact. And obviously, we don't have pharmacy in rural areas. And without any recognition that rural practices dispense due to this absence of local pharmacies, general practice is acknowledged as the bedrock of neighbourhood health within the framework. And technology use is promoted to improve GP productivity. And yet there's no reference to the lack of connectivity and broadband availability in rural areas. I struggle to do telephone consults because there's no phone reception. But none of this is mentioned within that neighbourhood health framework, which is frustrating. ICBs are supposed to strengthen the pharmacist role in healthcare delivery. Again, there's no reference to dispensing at all. So we are missed out. And there's no reference to geography. There's no reference to how the neighbourhoods would work in rural populations. This multi-neighbourhood provider contract is designed for populations of 250,000 or more, and single neighbourhood provider contract is for populations of 50,000. The size and shape of neighbourhoods to be agreed with local authorities as part of the planning process, it just doesn't work over huge areas. There's no mandate on nationally defined sizes, and there's no reference to rural populations at all. So given that these populations have not even been considered by policymakers, who may not be rural GPs or those delivering care to any patients who face inequity, this feels utterly inadequate. There needs to be, within the neighbourhood development, some flexibility to adapt for local need, because this will not work in rural areas.
Part of the plan, obviously, a really big part of the plan is to shift more services out of hospitals and closer to people's homes. I mean, how could that work in rural areas? Because it's quite unlikely you're going to have lots of neighbourhood health centres where you'll be able to put all these services. So how do you see that working in rural areas?
It's a really important question. In rural areas, one way to bring services closer could be through mobile clinics or telehealth solutions. But instead of relying on a big neighbourhood health centre, these options can allow care to reach people where they are, making healthcare more accessible, even though when facilities are sort of far apart. But the elephant in the room here is that the problem comes from the lack of NHS investment in estates. So centralising services brings with it the idea of cost reduction, with maybe not seeing the long-term consequences of short-sighted, politically friendly cost reduction, when expanding estates locally is in the population interest. Ultimately, we could deliver services in our GP practice with secondary care outreach clinics if we had the room. But because we don't have the room and there's no drive to invest in space, that is, again, it's another block. Again, it feels like a scenario where rurality is not recognised as being a problem and rural access inequity is not recognised in the system.
That just seems like the most sensible solution, doesn't it, for rural areas? If you had bigger, better equipped GP practices in villages and towns, then you would be able to provide more services there, wouldn't you? And basically address all those problems we've been talking about how far away people are from hospitals and stuff.
Yeah, and also it would deliver better care because our patients trust us.
Yeah.
So if they were offered an appointment with a cardiologist that they didn't know, but it was at our practice, they're much more likely to come. They're much more likely to really engage with it because they know that we're endorsing it. There's a kind of that additional benefit which is lost in policy where patients trust us. So healthcare delivery in the general practice is going to deliver better health outcomes, which will actually ultimately save money.
Yeah, definitely. Obviously, the kind of idea is about building on what PCNs have done. How have PCNs worked in rural areas? Have they been a success, do you think?
This is a bit of a mixed bag. Rural PCNs have worked in some places across the UK, but sort of unevenly. So it kind of depends on how your PCN is made up and how it behaves. So if all members of the PCN are very rural and the area is huge, then there's enough flex within the system to separate out funding, because ultimately centralising services into one space is not going to work if you're covering a huge amount of square miles. It just isn't going to work. It's absolutely an urban model. And it will work in an urban area. You can see how 5 practices working within 2 miles of each other could work really well together and have economies of scale and save money. So you can absolutely see that. So I think in the areas where practices are very, very distant from each other and they're all covering the same sort of geography, that also could work because they'll just agree we just separate out the money and carry on as we were. The example of my own practice, we are the only rural practice and our other practices are all urban. And that's a challenge for us because anything that the PCN does together, our patients don't access it. And that's evidence. So there'll be really good ideas that go forward, but when you look at access, our patients aren't accessing them. So all that's happening then is services are being centralised and our patients are being marginalised.
That means that your patients are not benefiting really from some of that funding that's coming into PCNs, which are enabling them to do those things.
Yes, and this is completely unrecognised. It's a massive problem given that when you look at rurality, 1/5 of the population are living in a rural area. So that's a huge population to marginalise.
Obviously, as we've talked about, most practices in rural areas are dispensing practices. Can you just explain a bit about how important dispensing practices are in those rural areas?
Dispensing practices are vital to rural areas. We exist where the population density means a pharmacy wouldn't be viable. And it's a great model. The idea that you see your doctor, you need some medication, you go and collect it without ever having a prescription in your hand, it's an awesome service, which our patients really appreciate. If they had to drive to the nearest town, they wouldn't or maybe couldn't, and that would be a huge problem for their health equity.
There are lots of challenges with dispensing at the moment. I did a podcast a little while ago now, maybe it was last year, with the Dispensing Doctors Association, who I'm sure you know, Dr. Richard West, and we talked through some of these. But just so people listening to this episode know, can you explain a little bit about some of those challenges that make it really difficult financially for dispensing practices?
I could do an entire podcast on this.
Yeah, no, exactly.
I will try and keep it brief and also narrow it down probably on just 2 issues. One is the dispensing fee. So this is a fee that's attached to every prescription. The purpose of the fee is to pay for the staffing and infrastructure required to prepare that prescription. And it's funded through a fixed envelope, which is inadequate anyway, but that's an aside, meaning that the total amount of prescriptions raised in the country is divided into the total envelope. So the more prescriptions created nationally, the lower the fee per prescription. And that is a massive problem, particularly after COVID. So hospital waiting lists are huge. I'm not sure why, given that consultant numbers have been rising exponentially while GP numbers are going down, but that's a separate podcast. And so people are waiting longer for appointments, and they're needing more prescriptions to tide them over. And therefore, as prescription numbers increase, the dispensing fee decreases, and that value of the dispensing fee no longer covers the staff and the infrastructure. So the deficit is borne by the business, which is not sustainable, which is contributing to practices closing. That's my problem one.
Yeah.
Problem two is clawback.
Yes.
This is extremely frustrating. So dispensing doctors have this thing called clawback. Pharmacy does not. It is around 12% reduction in payment for NHS medications prescribed. It comes from this ancient idea that dispensing doctors, who are small businesses, can somehow negotiate better discounts on drugs than Boots. And guess what? We can't. So we buy drugs at a certain price. There's an NHS tariff that will be paid for them with a 12% reduction for dispensing doctors, which is entirely unfair. And there are many drugs that leave our building that have created a cost deficit. So we are giving the patient that medication that has been a loss leader, but we do it anyway because we care about our patients. But we do need to recognise that in the current climate, this is not sustainable, which contributes to GP surgeries needing to close. It's a very real problem with a very, very easy solution. Get rid of clawback, allow dispensing doctors, who are small businesses, to have exactly the same rules as the huge pharmacy chains. We're not asking for a more favourable deal, just parity.
Yeah. Do you have the issue as well about not being able to sell over-the-counter medicines as well, like a local pharmacy?
Yes, absolutely correct. Yes, we can't. So a patient can come in and want to buy something from us, and we have to say, no, I'm sorry, we have it on the shelf just there. You can see it, but we can't sell it to you because the rules are different.
That's kind of madness, isn't it? I mean, if people have then got to drive a long way into town to get it, and they could have got it from you.
And they can't, or the pharmacy's closed. Yeah, it's madness. It's just ancient rules that haven't been changed because dispensing doctors are seen as being such a minority that they're not worth focusing on.
But they're not, are they, though? There's actually a surprisingly large number of dispensing practices. I mean, they obviously are in a minority, but it's a fairly substantial number, isn't it?
Rural is almost a fifth of the population.
You've said that you think that rural practices, rural policy generally, is kind of overlooked by the government. And so do you think there needs to be a more tailored approach for general practice in rural areas? And if you do, what should that look like?
I think obviously more support would always be welcome. I'm not sure what that would look like. I think as a cohort, we are really resilient. We need to be. And that's almost reflective of the population we serve. Our farmers, for example, are extremely resilient. I think ultimately my take-home message would be that providing healthcare in remote rural environments has additional challenges. There's this thing called geographic narcissism, this unconscious belief that the big cities are the centre of everything, and that leads to that subtle devaluation of rural knowledge and need. It sets rules and policy that are urban-centric, and they just don't fit a rural model. Rural population health suffers, and it's hard to work in that environment. So it's not really support that we need. We just need all policies to be rural-proofed, and then our population health will improve, our recruitment will improve, and our staff will be happier.
One of the things that's kind of happening now, well, it's already started, it started this year, it's going to carry on next year, is ICBs being slashed in half. This is in England. Obviously, a lot of them are merging, they're getting bigger. I mean, do you think that potentially could cause problems? Because if you've got a much bigger ICB that perhaps has more population in urban areas and basically people who are further away from you don't understand the challenges in your particular patch in the ICB. Are you worried about that causing potential problems?
Yes, I absolutely am. I think that the bigger an organisation becomes, the more difficult it is to recognise individual practices' specific needs. And on this, that's health inequity generally. So it's not just rural. There are different practices with different problems. So the bigger the overseeing organisation, the more urban-centric or the more generic the provision is. And all policies need to have that flexibility to be able to adapt to a specific local population. Obviously, for me, that would be rural. For other areas, it might be a specific homeless population or a specific asylum seeker population. There may be different populations, but the bigger you become, the more these marginalised communities become lost. And that really, really worries me because these people have higher health needs in the first place. So if we create a system that makes it more difficult for them to access healthcare, that's a problem.
It's been brilliant talking to you, Emma. Thank you so much for coming on the podcast.
No, thank you for inviting me. I've very much enjoyed it. Thank you.
Well, that's it for this week. We've put a link to that podcast with Dr. Richard West from the Dispensing Doctors Association if you're interested in more information about dispensing practices in the notes for this episode. Thanks again to Emma for speaking to me this week, and thank you for listening. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.